Good evening, one and all. Welcome to today's webinar, Coma Rehabilitation Programme. I, Dr. Asmita Mohorkar, member of IAP Maharashtra State Executive Committee, will be
Please increase
hosting this
volume.
session. The subcoordinator of Pune district is Dr. Ankita Talreja. IAPWC was started on 30th May 2018. It functions under the guidance of National Head Dr. Ruchi Varshney and IAP President Executive Dr. Sanjita. IAPWC works towards conducting public camps, CMEs, workshops. It aims at bringing together all physiotherapy professionals for sharing knowledge and improving public awareness about physiotherapy. With head for each. Dr. Pooja Kamble is West Zone Head. The state team of IAP Maharashtra State, that is Chapter 2023, includes President Dr. Ujjwal Hegde, Vice President Dr. Abir Giri, Secretary Bharti, Treasurer Dr. Secretary Dr. Darshana Trivedi and Mansi Mehta. Executive Committee Dr. Sanjay Rajhans, Dr. Sohan Shilkar, Dr. Suraj Kanse, Dr. Rahul Deshmukh, and Dr. Asmita Mohorkar. The state team of IAPWC includes State Coordinator Dr. Suvarna Ganvir, Joint Coordinator Dr. Snehal Patel, Sub-Coordinator Dr. Uttara Mohan, Dr. Nirali Sangvi, and Dr. Priya Karande. In Maharashtra, IAPWC has conducted 40 plus low-cost activities in various districts. In April 2019, first corporate IAP conference held in Indore, where Maharashtra State received award for Best State IAPWC. Now, today, we all are fortunate to have an eminent speaker, Dr. Hamza Godhrawala, who is MSc in Advanced Physiotherapeutic Practice, PG Diploma in Cognitive Behavioral Therapy, PG Certified in Sensory Integration, Scotland. He is well-regarded clinician and expert witness with over 12 years of experience working with complex medical legal cases, along with his clinical expertise in various neurological conditions, especially spinal cord injuries and acquired brain injuries. He is currently involved in large multinational clinical trials across USA and UK, addressing stroke rehabilitation through vagal nerve stimulation. I welcome you, sir, on behalf of IAPWC Pune District and IAP Maharashtra State. Now, before moving on for the webinar, I request all the participants to please mute your microphones so that there will be a smooth running of the webinar. And those whoever is having a questions, please put it in chat box. So at the end of the session, we will try to give answers. Thank you. Now I request sir to please proceed further.
Very good evening to everyone. Thank you for taking time off on an evening and choosing to listen to my webinar on coma rehabilitation. Right, can everyone see my screen? If I can get the thumbs up from one of the organizers, that would be great. Okay. Right. The topic itself is quite challenging and daunting for clinicians across a variety of rehab spectrum. You will either have nothing to say, depending on the neurological insult the client has suffered, or at the other hand, you will have a lot to say and a lot to do. and that will depend on a prognosis which is good for the client. So basically, coma falls under a wide spectrum of neurological insult. Nothing to say or a lot to say. Uh, it's beyond the scope of this 1 hour webinar to try and cover the entire stimulation programs and details. What I will try and do is spend the first 5-6 minutes just setting up a background and making sure everyone is well aroused, and then slowly start taking you to a stimulation level and introduce some of the programs. Quite a few programs to go through. I will touch base on a few and talk in detail of one particular element, cognitive rehab, which is my favorite, which is my area of expertise, and try and share some knowledge which hopefully will help you treat coma patients in a slightly different way with a slightly different perspective. Okay, to begin with, what we mean by the term coma. So on a simple layman terms, you're basically looking at your patient as being unresponsive. Okay. So on the other hand, you want to make sure that a person is conscious or able to respond. And to be able to have that element of consciousness, you're reliant on two major systems in our. So your ascending reticular activating system, which is basically the system that keeps you awake. And once you're awake, very important to have a functioning cerebral cortex of both hemispheres, which will determine the content of that consciousness. So it's as good as saying that someone is conscious, but if the content in a way that he presents doesn't make sense, you're as good as having no element of consciousness. Moving on further, Glasgow Coma Scale, very important for us, both from an assessment and a management point of view. So initially, the level of the Glasgow Coma score will determine the level of consciousness and present a picture as to which category your patient falls. And as subsequent stages go on, there will be more of an assessment come diagnostic come prognostic tool. The score goes down, you know the patient is deteriorating. The score goes higher up in terms of improvement, you know the patient recovering. So very important to keep this scale in mind. I'm not going to go in details, just a teaser. You know 3 elements: eye opener, verbal and motor response. Each of them very important to be assessed in detail, in thoroughly. I'll probably skip this part. This is more of the physiology element of a vegetative state compared to the cerebral hemispheres. But something, if you guys are interested in, and someone who works more in this particular environment of ICUs dealing with comatose patients, a very good sort of continuum spectrum to go into detail that gives you the different levels of consciousness as the patient improves. Now, when you're addressing coma patients, first of all, you want to make sure that is the patient actually, diagnosed or labeled with coma. I wouldn't worry too much about this. Leave it to the medical team. Let them diagnose. Let them label the patient coma or recovering. Our job, irrespective of whether the patient is in coma or not in coma, is rehab. So I wouldn't worry on that element of making a diagnosis of the patient is comatose or recovering. But just at the back of your mind, when you're dealing across such a continuum of patients, when you say the patient has gone into coma, you just have to have a brief idea saying, okay, when they say the patient is in coma, you're looking at there is no response with the eyes, there is no sign of wakefulness, and there has to be an associated neurological insult for the clinician to be able to make a diagnosis or come across a justification saying the patient is now in coma. At a very basic level, the main thing that should come across your mind is there has to be the involvement of the brainstem. So your main respiratory centers being compromised and your brainstem being compromised, depending on the type of injury, and that could be an indicator that yes, this is the possible reason for coma. There has to be involvement of the brainstem. Now, unfortunately, 1/3 of those patients will die within a month. Now, this is what I'm talking about, the insult being quite severe and there are no signs of recovery at all. So 1/3 of those patients will die. Majority of that happens because along with the brain injury or the neurological insult, there tends to be the multi-organ failure setting in. So your lungs, kidneys, so unfortunate for the patient. Now, for the remaining category, the coma status gradually starts resolving. So you're seeing signs of recovery. But that could take a minimum between 2 to 3 months in survivors. So it is quite a big period. Uh, even if you take the lower end of 2 months, 2 months is still a big period for us to be able to then proceed with actual rehab. So just keep these two things in mind, that not all patients in coma will die. Not all patients will recover very quickly. Even they will vary across the spectrum. Okay, very quickly. So you will either have the patient presenting with what we call a vegetative state, and this is more the lowest sort of site of recovery. No, there is no cognitive awareness. Now, if at all there are signs of improvement, you're seeing what we call a transitional phase. You might see some spontaneous eye opening happening. With that, you will come across sleep wake cycles. So you know that, fingers crossed, this patient is showing signs of recovery. We might see some response happening. But at this stage, you will have no expressions, no behavioral responses to any external stimuli. So you're still on the lower end thinking chances are very dim the patient will recover. Moving on, if there are signs of recovery, the patient will fall into this category, what we call the minimally conscious state. Now, these are some very basic characteristics you will come across when you see a patient recovering with the vegetative state. So you will have some elements of intelligible verbalization. You might be able to follow simple commands, more of a yes no response, and there might be some sort of trigger response to external environmental stimuli. The last element, accommodation to shape and size, is variable. I mean, at a very basic level, if there's some amount of movement that you see and you try and give an object in the hand, you might see the patient adapting to it. If that is a sign you see, good, very good. You're happy that this patient will make more progress. So that is something you want to keep in mind when you're assessing the patient as the stages go ahead. For the recovery, very quickly, the patient will then fall into the confusional state. So you will have more of an interactive communication, which may or may not make sense. More importantly, from a behavioral response, you will either have the patient not speaking at all, or you will have an agitated response. Again, cognitive elements will severely be depressed, and majority of cases will have an episode of what we call the amnesia. So they will have no memory or recovery recall of what happened. So this period is quite sort of important. Now, as I mentioned previously, and very quickly to create a more of an insight, there has to be involvement of the brainstem when you're talking about coma. No hesitation of that. I'm a big fan of cranial nerves, and I would strongly recommend neurophysios in particular who are in this area. You need to get your cranial nerve testing spot on. No sort of hesitation. It shouldn't be done without an element of doubt. Shouldn't be rushed and shouldn't be ignored. Two reasons for that. Number one, just a brief light on the neuroanatomy. So you have your cranial nerve nuclei emerging from the brainstem, majority of them, midbrain, pons, medulla. So following any type of injury which results in a coma, say for example, a traumatic head injury, or a person with suicide ending up with a head injury, there is going to be an element of bleeding inside the brain, and falling on the simple physiological principle, the brain has no place to expand, so the skull is protected. So the contents of the brain are constantly fighting against each other to make some space, to preserve their space, which ends up in swelling, which ends up in inflammation, And once inflammation sets in, your cranial nerves start getting affected. So cranial nerves will play a very important role right from the beginning in terms of assessment. And as you start the rehab process, as you do the cranial nerve assessment, again, you will see signs of recovery of those cranial nerves. Secondly, what you want to make sure is not rush into a judgment of labeling a particular cranial nerve palsy. Unless it is very obvious that you see a sign of a particular nerve lesion, you label that this particular patient has, for example, the third nerve palsy or the fourth nerve palsy, but do not rush into it. The reason I say that is because if it's just pure inflammation, as the status improves, the inflammation and the surrounding structure will start regaining their original positions in the brain. And so the cranial nerves will also start recovering those functions. So it's important that you do not label that person having a particular cranial nerve palsy. One nerve to keep in mind is the sixth nerve. More than 90% of any neuro cases will show that particular nerve palsy, but that is a false positive. The reason for that is the sixth nerve has a slightly longer route compared to other cranial nerves, except the vagus, which goes up further into the heart and the digestive system. From the other cranial nerves, the abducens nerve has a slightly longer route of exit. So you can imagine a brain being inflamed, it can get affected at any part of that abducens nerve, and it will straight away give you a lateral gaze palsy, and you say, oh yes, this person has a sixth nerve palsy. No. As soon as the inflammation stops, that resumes back to normal. But this is a good prognostic sign for us. And the last bit from the assessment point of view, the doll's eye reflex. I'm not sure how many of you know what the doll's eye reflex is, but before I just introduce that and give you an idea of that, a word of caution, do not do this on your own, especially if the case is of a cervical injury or more towards a brainstem herniation case. Strongly advise you want to make sure there is a senior neurology registrar or a consultant when, if at all, they allow you to do the doll's reflex. Because what you're basically doing is, for a normal person, a doll's reflex is when you turn the head to the left, your eyes also go in the same direction. The vestibular and ocular part works together. With the brainstem involvement, what happens is you move your head to the left, the eyes go on the right. So that sort of opposite reaction, doll's eye, what we call, straight away you know it's a brainstem involvement, but you want to be very, very, very cautious and not do that. But at the same time, at some point in your life, as a physio, as a clinician, you want to make sure you see that reflex. Very important. Go to ward rounds, ask a consultant to demonstrate that, and you'll be amazed to see. And that is the one secret why they label the patient in coma straight away very quickly as well. Doll's eye reflex positive, comatose, brainstem herniation. Okay. Right. Is everyone awake so far? I can see some smiling faces, so that's it. Good. Okay. Important element for us. So we've done the assessment in terms of a proper, full neurological assessment, and I would put more of my emphasis on the cranial nerves. The reason I mentioned why that's so important. And then, of course, you want to start the rehab journey. That's what our main responsibility is as physios. So quite self-explanatory on this slide here. You will come across what we call the acute stage, wherein the patient is in the ICU, ventilators, multi-organ management. Gradually, as recovery progresses, they go back into community. And once they're back into community, we have what we call long-term case management. So depending on the area you work, you could be involved in either one of those specialties or all of that if you're someone who works across all those spectrums. Now, when you start planning your rehab goals, you want to make sure you include at least these 4 elements in your protocol or in your management plan. Glasgow Coma Scale, as I mentioned before, assessment, prognostic, diagnostic, very important at all stages. And then there are quite a few different outcome measures, but majority of us prefer these two, and they're quite good. The Amigo scale and the JFK Coma Recovery Scale. The reason we choose this in particular are because these two scales, they work on a hierarchy pattern. So the highest element of that particular outcome score is based more on a cognitive level, and the lower element of that score is based more on the cerebral cortex functioning and the brainstem functioning level. So if you're somewhere in between the score, it gives you a good prognostic level that the chances of recovery are very good. And then again, my hands on, my bet on cranial nerves, very important. Now, majority of us as physios, the tendency is to rush into what we call restoring movement, which is fine, which is obvious, and that's what we need to work on. But there is an important element of cognition which is either ignored or missed, or or because of a variety of reasons, lack of resources or lack of time, or sometimes even lack of knowledge, this element is not addressed. And the key message for rehabilitation, in our case, in today's topic for coma rehab, or for that matter any other neuro insult cases, you have to make sure these two are addressed equally. Otherwise, it is hitting a bullseye with your eyes closed, and things can get a bit more complicated and messy. I will explain why they go hand in hand and the importance of addressing in detail as we go across stages. Now, I think we got someone's mic on. I can get an echo. Yeah, perfect. Okay. Now, if you read the the header, the purpose is spelled the other way around. So it's basically reading as positioning. You want to make sure the positioning is absolutely right. You get the positioning wrong for a start, and you're not in a good sort of recovery pattern for that patient. Now, this is more for third year students, and I'm sure experienced clinicians know the importance of positioning. I'm not looking at answers for. Can you hear me? I'm getting a connection error here. Is that okay? Okay, perfect. So when I mean positioning, I'm not looking for answers saying positioning is important to prevent bed sores, to prevent contractures, to maintain joint range, X, Y, Z. That is standard second year, third year answers for students. The reason why positioning is so important is when you start treating a patient recovering from coma, you have to keep in mind you're as good as treating or working with a kid, a newborn kid. So the way you position, the way you treat, the way you introduce things is what is now going to form a new pathway. And hence the importance of getting positioning right. Now, at a very basic level, you're looking for following the rule of 30 degree. Very quickly going to go through 3 points for that. You want to make sure the head end of the bed is elevated not more than 30, hips and shoulders in supine at 30, and making sure those are supported with pillows and wedges, whatever available equipment you have at your hospital setting. Now, one element of importance here is majority of patients who've been in coma. One important fact is also going to be a rise in their intracranial pressure, and most of us lie down flat during the night. So will most of these coma patients do, with or without ignorance of the nursing staff to keep their head and elevated. So what tends to happen is nighttime, our venous returns are at risk, and eventually when the patient wakes up in the morning, the main complaint is nausea and headache. And as a physio, if you're going to see the patient first thing in the morning, the patient would say that I have a severe headache. That's it. You make a note in your note saying patient declined because of headache, and therapy doesn't happen. At least I used to do that because I didn't know the reasoning behind this. But secondly, I was also very happy during my college days that at least one patient less at this point of time now. So what you want to make sure is if you intend to see these patients as part of your rehab. If they've been lying flat throughout the night, instructions to the nursing team that first thing out in the morning after they washed and dressed, bed in at 30, so that allows some amount of the ICP to settle down, and the headache will be relatively less, if at all that's a major complaint. Okay. Then you want to make sure you're doing what we call a slide sheet transfer. Now, we are still at an acute stage. The patient hasn't been sitting up or being able to mobilize at all. So all we're doing is basically doing bed mobility. Now, you've got to be very careful and not try and do too much of hands-on approach with more of manual handling, because you're going to hurt your back, and at the same time there is already a lot of injury to the patient, so that's not a very good idea. You want to minimize the risk of shear forces at this point of time, so you want to make sure you use slide sheets as a way of positioning the patient. Two reasons. Number one, like I mentioned, reduction of shear forces, important to give what we call comfort care to the patient as opposed to rough handling with our hands. And secondly, when you start using a slide sheet, you're basically introducing a very small element of sensory stimulation, which is going to play a major role in the coming rehab programs of coma stimulation. So with the person sliding up and down sideways using a slide sheet, you've introduced an amount of kinesthesia, an amount of proprioception, and these two sensory systems are very, very important for our sensory stimulation programs in later stages of rehab. And then if you have the luxury, you can use specialized positioning equipment in the forms of wedges and cones and stuff. There's a lot of stuff in the market now these days, highly specialized. The only problem in a slightly less resourceful area is with pillows. The pillows will not maintain that sort of positioning for long, so that is a slightly drawback. So you want to make sure you start introducing wedges and other specialized equipment for positioning. Okay. Let's have a look at the time. I might leave this video in the end. If not, people can always sort of use this link and have a look. This video in particular shows a very basic slide sheet transfer process. The main sort of mechanism is same across coma patients. The only thing that you keep in mind here is minimum 3 staff required. 2 staff doing the maneuvers and the third staff taking care of the surrounding equipment. Less than 3, you're inviting a bit of risk to the patient, and you do not want to do that. Okay. So now we start moving on to a gradual, more recovery, phase. So you want to introduce what we call a sensory stimulation program to these patients. At a very basic level, what you're expecting is some amount of arousal and behavioral response using some stimuli. And you're targeting our main sensory system domains. So your kinesthesia, your proprioceptive, auditory, visual, and tactile. Some key features to keep in mind. I'm not going to go into details of how you do a particular sensory stimulation program. Lots of protocols across, and even for a fresh physio who just passed out, you're basically looking at some very common sense things, just different vestibular or auditory or proprioceptive systems. And there is no involvement of highly expensive equipment. You're using your activities and your equipment of daily living. All you got to keep in mind is before you start a sensory stimulation program, you want to do some good homework. And what I mean by that is you're having a brief assessment with the patient's family, because you want to know the patient's likes and dislikes from across the whole lifespan of that patient, in terms of food, in terms of people, in terms of entertainment, social life, hobbies. You have a proper list of what the patient likes and what the patient dislikes. And one very important factor to keep in mind before we start sensory stimulation is, say for example, a case of suicide, when you gradually introduce what we call visual stimuli. So you get family members across the patient. You want to make sure that the person who's responsible for putting that patient in a coma state is is not coming across anywhere near in that earlier stages. So this is where there has to be a very good homework. Say, for example, if I was the reason that person is in coma, you shouldn't allow me in front of the patient at any point unless the patient is returned back home. If you do that, you're introducing what we call a noxious stimuli to that patient, and unfortunately, no matter how hard you work, your chances are getting dimmer and dimmer because the patient is absolutely furious with you. The patient knows that this person was the result. He ended up in coma, and you're introducing that person at the first point of contact. So make sure you do some thorough homework and do not rush into going for a sensory stimulation program. Now, like I mentioned, at a basic level, you know you're working on your four or five sensory domains, and we all have a wide range of sort of equipment or common sense or what we call abilities to play around of what we want to stimulate. But at a higher level, you want to start thinking as to what you want to introduce in terms of sensory stimulation, how you want to introduce that, and more importantly, what effect is it having on the brain? Because you just do not want to introduce all the stimuli together and start arousing the patient. This is where you need to start sort of differentiating and labeling your sensory programs. So what you want to make sure is you want to use a term called sensory modulation. So you want to make sure the stimulus is right. Someone might need what we call a very high level of stimuli to arouse. On the other end, you might need someone to calm down. So you want to introduce calming strategies as opposed to more of arousal strategies. So you need to modulate your sensory program across these two wide sort of domains. Whenever you do that, you want to make sure you're trying to create a balance between the excitatory and the inhibitory mechanisms. This should be at the back of your mind. So you're not introducing something which excites the patient too much and there's no inhibitory response, or your program is too low in a stimuli that it is just inhibiting the responses and not creating any excitatory response. Try and get a balance. Easier said than done, very difficult, but comes with practice. And eventually what you're looking for is activating the limbing system process. So there is a big element of emotional sort of pattern across coma stimulation programs. So you want to make sure that eventually whatever you do makes sense in terms of giving sufficient arousal to the limbic system. You do not want to rush into things. And then there are key elements of what we call cognitive processing, which I will talk in detail, and the process of habituation. Is everyone okay so far? Good. Okay. How are we doing with time? Okay, not bad. Another very quick sort of stimulation program that we commonly use is the median nerve stimulation program. Now, this is a highly specialized area because initially you're looking at doing nerve conduction and EMG studies to find out velocities and the muscle firing potential of that particular nerve. And then depending on the response you have, you start stimulating the median nerve. But there is strong evidence that stimulation of the median nerve improves what we call cortical processing information. The reason we do that is the median nerve has a slightly larger cortical representation in the brain compared to other nerves. And as we know, as we come across a basic sensory physiology, sensory homunculus, so smaller areas of our body have the larger representation in the brain. So you want to stimulate the smaller areas to get larger areas of the brain fired up, speed up recovery process. And along with that, you also have projection pathways between the thalamus and the cortex for the median nerves. So basically, you're improving fine coordination skills, grasp, release, and all of those activities by stimulating the median nerve. So very important element of median nerve stimulation. At a basic level, if you do not have the resources to do the EMG and the NCV, you want to make sure the patient is medically stable and there is some amount of response to the median nerve stimulation. Just learn up your motor points where you can stimulate the median nerve and start off at a very low intensity and gradually work your way throughout. There is no limitation or restriction that if you do not have detail of NCV or EMG studies, you cannot do this. But you have to be careful. You cannot introduce a very large amount of electrical stimulation straight away for this. Right, now I'm going to spend the rest of this session introducing this particular element of coma stimulation, what we call cognitive rehab. This is an area I enjoy working with and spend a lot of time. As I mentioned before, with movement, with action, there has to be an element of cognition, otherwise you're not doing justice to the patient. And the reason I say that is, following a neurological insult, the internal patchwork is now disturbed. So the external reality will be affected. Depending on the insult and depending on the reality, you have to start working your physio rehab program. And this plays an important role, not from just the cognitive element, but what you plan from a physical rehab point of view. So if the patient has a very intense patchwork, you start working at what we call a new reality program. You know that the previous recovery will never happen now, so you start working towards a new program. If the patchwork is reasonable, then you know that, okay, I can start working toward what we call compromised elements. And if the patient is lucky, the insult is not that great, there are very little patches, you start working towards what we call normality. So these are the three phases your rehab should fall into. Either a completely new pattern functional recovery, either a compromised recovery, or a near normal recovery. Very important for us to understand that of the wide range of cognitive domains, four main important ones: your attention and concentration levels, your ability to process information, memory, and executive functioning. They all work, unfortunately, hand in hand. So if one is affected, there will be a knockdown effect on the other. Depending on the part of the brain injured, the knockdown effect will vary. But it is very important that you address all of these elements when you start preparing your rehab program. At a very sort of basic understanding level, you start, for example, some mobility exercises with your client. For the half an hour session, the client is following you because it is doing what is more of a visual sort of feedback. So because initial stages you're doing more of a passive approach, the client is happy because he's not doing much work, because there is minimum amount of information that he's processing, because all you're doing is passive stuff to him, so he has nothing to do and it's not sort of processing any information. And you expect some sort of information to be retained when you see the patient the next day. You see the patient the next day, patient has no clue what's happening. So you get frustrated as a therapist. The patient is already frustrated. So if there was a slight sort of slowing approach and had you paid attention that, okay, this patient is not able to process information, let me work on that first and then start moving on to more sort of, movement therapy. Because as physios, we want to rush mobility, balance, get them walking, get them home. Fine, that is good. But you want to make sure you start realizing that an element of cognition has to play. Otherwise, things can not get very, very good in terms of recovery. Okay. To try and explain this particular area of coma stimulation, I'll present a case and show you a video of an assessment and a therapy session that I've done, so that will make more sense other than just talking on all of the stuff. So we had a 67-year-old female lady, head injury when she fell off from a bike, rushed into the A&E initially, GCS score of 11, which is reasonably good. pupils equal and reactive to light, so good sort of optic nerve, responses as well. But there was some amount of focal neurological signs of meningeal irritation, so neck stiffness and headache. So probably before rushing into investigations at the back of the mind, you start thinking could be a case of subdural hematoma happened here because of the head injury. And the only medical history that she had was hypertension, otherwise fit and fine, no other positive history. So, as part of the initial management protocol, the consultants did what we call a cerebral MRI, and they found out mass occupying lesion somewhere near the brainstem. It's difficult to appreciate here, but this is what they found out. So after the patient was stabilized medically, they did a CT scan and found out there was a meningioma, and the size and the staging was quite severe. So it was decided to remove that straight away, work on craniotomy and get the meningioma removed. Now you can see that picture on your screen. It's a bit difficult to appreciate without actually seeing the whole brain. But if you can just sort of recover your brain anatomy, the circle of Willis, the involvement was such that as soon as the vertebral arteries they sort of bifurcate into the posterior communicating arteries, the the meningioma was sitting right on top there. So the involvement of the brainstem was at high risk. So you had your vertebral basal arteries being affected, and at the same time, going further up the circle of Willis, your posterior communicating arteries being affected. So it was a tricky sort of case to manage, but surgeons managed that and then started the recovery process for that patient. So like I mentioned, acute stage, you did your positioning. Once the patient was sufficiently alert, we started getting her on a tilt table to promote what we call more of proprioceptive and kinesthetic information. These two are very important. Whenever your patient is stable, medically stable, and you have the right resources, you want to make sure you start promoting some element of weight bearing straight away. These two sensory systems will play a major role in then sort of tuning up your other finer sensory systems of what we call auditory, visual. Because as physios, eventually you want to make sure the patient is walking. So for argument's sake, I might take it that if the vestibular system or the visual system is severely compromised, the patient will still walk, if you know what I mean, because the weight bearing processes have been developed. So you want to make sure you start introducing this very early. So this is a recovery stage. We started off with a tilt table, and initially this was as little as 10 to 15 seconds. That's it, not more than that. 15 seconds of a gradual tilt over. The feet are supported on the pillow, so the patient is now starting to get what we call the feedback processes. Kinesthesia, proprioceptive, very important. Now this lasted for around 6 to 8 weeks in a combination of what we call the supported standing. So we were just sort of focusing on proprioceptive kinesthesia. Initially tilt table, later on a standing frame, supported standing frame, weight bearing. If you can have a look here, her feet are completely supported against the bed, and she's leaning. But as the machine goes up, you start pulling the patient further up. So they're more of in that alert position. They're fully supported, so they do not feel unsecured. Easier said than done when you start doing this, they scream and scream and scream. So very difficult stage. So these two stages lasted for roughly 6 to 8 weeks. So you can see it's not an easy process to start working on a coma rehab patient. Moving on further, after that, we started what we call supported walking. I wouldn't actually call this supported walking, it was more of further weight bearing promotion. Now, if you just sort of compare the previous two slides here in terms of body mass as well, initially when this was the acute stage, hands and limbs quite swollen up. Gradually, you see the amount of muscle atrophy there, especially the hands and the feet. Major bulk muscles, so you can imagine the amount of muscle memory that's been lost. So on a normal basis, you would start working on strengthening exercises at a later stage, but you want to keep this in the back of your mind that is a patient prepared to take that weight without that necessary supporting devices. When you use an equipment like this, the amount of strength required from the person physically is 10 to 15% only. 80% of the work is done by the machine. So you're building an element of confidence in the patient. And then eventually working on a pulpit frame. This is after a good 2 to 3 months. Okay. 6 months later, patient medically stable. Unfortunately, despite the best efforts we made in terms of mobility, all she could manage was step transfers only. So, just getting up from the bed, using that pulpit frame to go to the toilet or back, and nothing more than that. And the reason for that was there was severe cognitive impairments across all major cognitive domains. So she couldn't understand or process information to make sense, to have that memory. So no matter, even if you have 2 or 3 sessions every day of mobility, the moment you look for a feedback and the moment you look for an automatic response, she just wouldn't walk. She wouldn't feel secure. She would say no. Almost done. So that's us for this particular brief session on this. Just key points to keep in mind. Coma patients, you want to make sure you're doing a continuous assessment, constant adaptation, having a flexible approach, and my bet on action and cognition, they have to go hand in hand. So that will optimize results for us rather than just focusing on the movement element alone. Thank you very much. I'll take this opportunity to thank Ganveen ma'am in particular. It's been around 15 years since I last left the institute, and learned a lot of stuff from Ganveen ma'am in particular, from a neuro perspective, and other professors in our college. So I'm lucky I got this opportunity to share some of the knowledge that I've learned in these years. And of course, the organizing committee, thank you very much.
Thank you so much, sir. So we'll be going for the question sessions right now. We have few questions for the same. The first question is how to differentiate clinically between coma and locked-in syndrome.
Can you hear me?
Yes, sir.
Yeah. Okay.
So for the question sessions, so did you hear the question? The first question is how to differentiate clinically between coma and locked-in syndrome.
Okay. I'll bring this slide across if you. For very, very basic understanding, you want to make sure that the patient is either conscious or unconscious, and this is where you start differentiating it. So people with locked-in syndrome will present more of what we call a decerebrate, decorticate sort of presentation, and majority of them will have what we call an element of consciousness with them. In terms of brainstem involvement, what will be presented in a locked-in syndrome will be slightly different compared to a comatose patient. So for a comatose patient, the bilateral cerebral hemisphere involvement is for sure. For a locked syndrome patient, there tends to be a unilateral involvement at times, and hence you see some amount of a variable movement pattern in those patients. So this helps you sort of distinguish between the two.
Thank you, sir. So the other question is, why we can't perform the Dole's reflex alone, and if it is done alone, what will be the consequences?
The reason I say that is for specific cases of, for example, spinal cord injury that has led to this particular brainstem herniation process and the patient is in coma, you could be doing further damage because it is done in a slightly vigorous manner. You're holding your head and you're moving it across in one particular direction. So if the patient is someone with a spinal cord injury, the chances are you're damaging it more. And like I mentioned, it is a very important vital sign. So you want to make sure as a physio, as a clinician, you see that for sure, because that brings in a lot of other cranial nerve lesions. But the amount of damage it can do if you do it alone is irreparable. So you want to make sure you play a safe game just from that point of view. The blame shouldn't come on you because, like I said, diagnosing someone with coma is not our job. Our job is rehab. And the Dole's reflex, once it gives you a positive sign, that means there's brainstem herniation towards brainstem herniation. So you want to make sure you play a safe game and you're not doing something that will further aggravate that. Because majority of patients, what will be done at some stages, if there are signs of meningeal irritation, you will do what we call a lumbar puncture. Now, if the lumbar puncture has been done, say for example today, and you start mobilizing the patient the very next day, you are then sort of increasing the chances of the ICP being raised up again. That will lead to further sort of what we call features of brainstem herniation, and you're inviting more trouble. So as much as they're important, hence I say under the supervision of a senior neurology registrar or a consultant, they are the experts. If something goes wrong, you're not responsible for that. In a nice way, you know. I'm not saying you shouldn't be doing it, but if your consultant allows you to do that, go for it. Is that okay? Hello? I think we've lost Ankita there.
Hello. Hello, sir.
Yes, I can hear you.
Yes, sir. So next question. If there is no recovery in the coma patients after 2 months, how to proceed with the rehab? Can you hear me, sir?
Yes, I can hear you.
Can I repeat the question?
No, I've got the question. I think your mainstay is then working towards positioning, and the reason the patient is not recovering is because the brainstem involvement is so severe that it is more of a respiratory compromise as opposed to the brain recovering in its functional capacity. So you're working towards maintenance of what we call more of a palliative approach. So all you're doing is positioning and passive movements to preserve that particular state of that patient. Because if you're reaching towards the end of the 2-month mark and there is no recovery, although cases vary, you're now sort of suspecting more of a dip down in that patient. So it is more towards a vegetative state as opposed to the patient now going to come back into a minimally sort of recovery conscious state.
Okay, sir. Thank you, sir.
Dr. Ankita, switch on your mic.
Do you have any other questions?
Yes, sir.
Yeah, go ahead.
So it was how to decide the, yes, sir. So how to decide at the cognitive level when to add the next level of complexities for the patient, and is there any scale to assess it?
This is a bit tricky to answer here in terms of what scales are available and what level to decide. The answer is in itself that there are a lot of cognitive scales, and when you do a proper cognitive rehab, I wouldn't say a degree, but more of a cognitive rehab sort of strategy, there are scales in those. Now, when you do a scale, the good point of these scales is they work as both as a treatment option as well as a prognostic option. So all those different 4 domains that I mentioned: attention, visual perception, memory, executive function, there are different scales and different activities to do. So when a person progresses, gets a higher score, you automatically know that you start introducing more complex elements.
Okay. Thank you so much, sir. Thank you. Now,
Ankita, your mic is mute. I cannot hear anything.
am I audible, sir, now? Yeah. Thank you so much, sir. That's it for the question and the answers. I'm Dr. Ankita Talreja. Thank you on behalf of IAP Women's Cells Pune for accepting our request and make time for the webinar. Thank you, Dr.
I'll just add up. It's been an absolute
Yes.
pleasure. I think we're losing out on connectivity, but like I mentioned before, an absolute pleasure for me. More of an opportunity to share some knowledge that I learned throughout these years, and hopefully, it's a bit difficult to explain things and show through a webinar. If things permit and I get an opportunity, I would love to, come across in an ICU setting somewhere and show you those sliding techniques, stimulation programs, and that makes a whole lot of difference as opposed to just sort of sitting in front of the camera here and listening. I'm sure half of you must have gone to sleep when I started the stimulation program. So.
Okay, thank you so much, sir. At the end, I would like to thank IAP Women's Cell Maharashtra, Dr. Sanjeev Shah, sir, Dr. Ruchi ma'am, Dr. Pooja Kamble, Dr. Suvarna Ganvir ma'am, State Coordinator, the Snehal Patel ma'am, Uttara Mohan ma'am, Dr. Priya, Dr. Nirali, for giving us the opportunity and throughout the guidance for conducting the webinar and continuing the source of learning in the lockdown. Thank you, everyone. So I have put the feedback form in the chat box. I request all the participants to fill the feedback form. Thank you so much, sir, for being there and conducting the webinar. Thank you, sir.
Thank you very much. Stay safe. Stay at home.
You too, sir.